Assalamu alaikum dear students. This is the second session on the topic of slave region. These were the objective which we previously discussed, and the objective which we previously discussed were we discussed what is slave region, then we talk about the classification of the slave region, we discussed the etiology of slave region, then the epidemiology and as well as the pathoanatomy and pathophysiology of the slave region. We discussed the sub-level variation and then the histopathology of slave region. After that, we discussed the history and physical examination of slave region and also discussed in detail about the special tests used in examination of surrounding region of the slave region along with their sensitivity and specificity. Then we discuss the differentiate slave region from other shoulder region, and this will be continue in today's session that how we can detect the slave region, um, how we can use the medical imaging, which medical imaging is more appropriate for the detection of the slave region. We will discuss the radiographs, we will discuss the CT scan, we will discuss the ultrasonography as well as the MR, and we will discuss that why MR is the most appropriate medical imaging as compared to the others. Also, we will also talk about some contraindication of the MR, and um, after that, if there is some contraindications, then the next secondary most appropriate medical imaging is radiograph, the CT scan, or the ultrasound. After that, we will discuss in today's session the physical therapy management as well as the surgical management of the slave region. We will talk about the surgical management for each type of slave region. What is the most appropriate surgical management? Plus, if there is a slave repair, so along with slave repair, what other additional surgical treatment is required? So they depend on which type of slave lesion is there. So we will discuss them. We will talk about the prognosis of the slave lesion. Specifically, we will discuss it in statements from the evidence that after the surgical procedures, what are the outcomes? There were good results, there were bad results. So, what is the prognosis of the slave lesion after surgical repair? We talk about the complication of the slave lesion, and then we will talk about the post-operative rehab protocol of the slave lesion. So, this is the slave lesion, which is the anterior superior tear and the superior labrum, anterior posterior tear. Specifically from that posterior superior quadrant and the interior superior quadrant. So these from 10 o'clock to 2 o'clock position, this is the most, and this is actually that area where the bicep tendon anchors. So bicep tendon is very highly associated with the slave lesion. These were the classification. These were the four type of classification. And these were the 10 types of slave lesion we discussed. Etiology. We discussed this peel back mechanism. Then these were the eight different types of classification, different types of the slave lesion or the slave tear. We discussed the epidemiology, pathoanatomy, pathophysiology, sublevel variation. What is sublevel foramen? What is sublevel races? And what is the what complex? This is the complete absence of the labrum in the interior superior quadrant, like we can see here. Sublevel races is sometimes this is confused with the slave region, but here there is only detachment of that labrum from that linear rim. And here there is a separation or you can say detachment in the anterior superior quadrant known as the sublevel foramen. There is if there is injury in the labrum in this posterior inferior quadrant from the 3 o'clock position to the 6 o'clock position. Then it is known as the vein cartilage. This is the reverse vein cartilage. In some studies, the glenoid cavity or the labrum has been divided into six compartments, quadrants, and the sixth compartment here, that is, this is known as the superior quadrant. This is from 11 to 1 o'clock position, and then from 1 to 3, this is the interior superior, and from that 9 to 11 o'clock position, this is the posterior superior quadrant. 3 in the lower region, from that 5 o'clock position and 7 o'clock position. This is the inferior quadrant, or we can say that the inferior region. And from 3 o'clock position to the 2 and 5 o'clock position, that is known as the interior inferior region. Similarly, from the 7 o'clock position to the 9 o'clock position, that is known as the posterior inferior region. So overall, every 2 hours is that is a single region is made up 2 hours from 11 to 1 o'clock, from 1 to 3, from 3 to 5, from 5 to 7 o'clock, from 7 o'clock to 9 o'clock, from 9 o'clock to 11 o'clock. And these are the six regions have been described. But in many regions, it has been just discussed in four regions, four quadrants. It is the posterior superior, interior superior. This is the posterior superior. This is the interior inferior, and this is the interior inferior. The posterior inferior. This was the histopathology. Then we discussed some history and physical examination. And we discussed that what are the relevant elements, pertinent mean relevant elements, which will make clear the nature of the potential slab culture. These were some of the components we have to discuss. This is the comprehensive examination of the surrounding region. So how if there is any problem regarding the radiculopathy, so swirling maneuver can be used to exclude them. Shoulder exam, these were some tests which we can exclude the shoulder other pathologies. These are the signs and symptoms usually present in case of anterior shoulder dislocation. Then we discuss in detail the provocative examination, for the bicep tendon, the speed test, the uppercut test, the ergaset test, pure hug test, the test, and the brain active compression test, the anterior slide test, and the supine resistance test. And then we discuss the myofascial test, which is also known as the modified or skull test or the modified dynamic shear test. Today in this session, we will start from the evaluation of the medical imaging in the slave region. Radiographic imaging is necessary for all patients with acute or chronic shoulder pain. If we talk about the radiographs, the clinician should obtain a true anterior posterior image of the glenohumeral joint, and that anterior posterior glenohumeral joint is known as the cruciate. ग्रेशियो में होता क्या है कि यहाँ पे पेशेंट जो है उसको 30 डिग्री तक तकरीबन जो है इसको एफेक्टेड शोल्डर की तरफ रोटेट किया जाता है और फिर इसमें जो इंटरनल रोटेशन एड की जाती है और इंटरनल रोटेशन के बाद जो है इनकी जो व्यू आती हैं दैट इज नोन एज द ग्रेशियो. इसके अलावा बाकी जो व्यूज यूज हो सकते हैं फॉर द शोल्डर पैथोलॉजीज दैट इज द एक्सिलरी लेटरल व्यू, द विस्ट पॉइंट व्यू, or the scapular view or the outlet. Auxiliary lateral view that is used just to check in much more detail about the relationship of the humeral head with the glenoid cavity. Axillary lateral view is also very important to assess and to check the humeral head along with the neck of the humerus. While scapular Y view is the lateral view, and it is commonly used in deciding and very clearly it can tell us that either there is if there is dislocation. So if there is dislocation, that dislocation is interior or posterior. And how we will know that there is no dislocation, we will discuss in the upcoming slide on the views. The acromioclavicular and the glenohumeral osteoarthritis, the calcific tendinopathy, osteochondral lesion of the glenoid or humerus fractures, dislocation, and bone tumors can be seen using the plain radiographs. This is the Gracie view, the glenoid cavity. This is and थोड़ा सा जो है तकरीबन 2 सेंटीमीटर जो है ये जो एक्सरे की बम्बारमेंट है रेडिएशन जो आयंस होते हैं एक्सरे की तो ये जो है यहाँ पे एक्सरेज जो है यहाँ पे बम्बार की जाती हैं जस्ट इन प्लेस 2 सेंटीमीटर below the distal cleavage. And clearly we can see that this is the relationship between the humeral head and the glenoid cavity. This is the acromion, this is the glenoid cavity, this is the joint space. This is the axillary lateral view. Patients 90, 70 तक भी जो है acceptable है. So if there is abduction of 70 to 90 degree of abduction, then after the abduction, the X-ray bombardment there will be in the axillary region, and the result will be like this. This is the lesser tuberosity, a greater tuberosity. This is the acromion, this is the coracoid, this is the glenoid fossa, and small contact between the humeral head and the glenoid fossa, and this is the neck of the humerus along with the shaft. So this is actually the axillary lateral view, also shortly known as the axillary view. This is the scapular Y view, and why this is known as the Y view, this is just appearance of this Y letter. This is actually the lateral view. This is the blade of the scapula, and this is the acromion, this is the AC joint, this is the coracoid. So in normal shoulder, the humeral head will be at the junction of these three lines, the two oblique line and one vertical line. So the circle where it is exactly the normal position of the humeral head, just like we can see here. This is the humeral head, and this is the junction of the two oblique and one vertical line. In the inferior dislocation, the humeral head is located where this green line is. This is actually the location of the humeral head, and normally location is that, and in posterior dislocation, the humeral head will be lying. So this is known as the scapular Y view, or simply the scapular view of the shoulder. So it's very important to listen about regarding the anterior and posterior shoulder dislocation. Magnetic resonance imaging and the magnetic resonance arthrography. These both are very commonly used to detect the slab lesion, and specifically when the contrast is injected, so it increases the sensitivity of the MRI. And not only the contrast media, the articular fusion as well as the traction of the arm and external rotation, these all will increase the sensitivity of the MRI in the detection of the slab lesion. Different contrast medium that can be used, and a moment 12 milliliter of that contrast medium that is injected in the joint line and अमूमन जो है ये अल्ट्रासाउंड गाइडेड होता है या सीटी स्कैन गाइडेड भी हो सकती है एमआर गाइडेड भी हो सकती है और ये कंट्रास्ट मीडिया जो है ये वहाँ पे विजिबिलिटी इंक्रीज करती है और अमूमन इसके कुछ ऐसे डेडिकेट लेजेंड्स होते हैं जो इस कंट्रास्ट के बगैर जो है वो विजुलाइज नहीं होती तो ये उसकी थोड़ी सी विजुअलाइजेशन जो है इंक्रीज करते हैं दैट्स व्हाई दैट इम्प्रूव द सेंसिटिविटी ऑफ द एमआरआई इसके अलावा जो आर्टिकुलर इफ्यूजन है कुछ लेजन ऐसे होते हैं जो व्हेन देयर इज आर्टिकुलर इफ्यूजन कुछ ज्यादा ही क्लियर नजर आते हैं जैसे सपोज द supraspinatus tear that is very clearly visible when there is joint एंड joint effusion अगर है भी किसी जगह पे तो ये थोड़ा सा पैथोलॉजिकल कंडीशन क्लियर कर देता है to make it very clear that there is a problem because normally there is no such brightness and because of that effusion which is the accumulation of fluid in that joint after the injury तो ये जो कि इंजरी के बाद ही होती हैं तो एक बात समझ में आ जाती है कि द ब्राइटनेस अगर हाइपर इंटेंसिटी जो इस फ्यूजन की वजह से आ रही है सो दैट इज ऑब्वियसली पैथोलॉजिकल एंड फिर लोकेशन देखा जाता है कि where this fusion is in the surrounding in the underlying of which structure which tendon which ligament so it again increase or improve the sensitivity of the that slab कंट्रास्ट मीडिया जो है ये मोस्टली जो है ये मुख्तलिफ अप्रोच से लेकिन इंटीरियर अप्रोच इज मोस्ट कॉमनली यूज्ड टू इंजेक्ट दैट contrast medium into the joint line. Clinicians should keep in mind the utilization of MRI may promote the poor diagnosis of asymptomatic और यही वजह है कि sometimes इस तरह होता है कि specifically in the overhead athletes कि ज्यादातर ओवर एथलीट्स में जो है ये डायग्नोसिस जो है अगर हम उसकी बेस पर कर ले एमआर की बेस पर करें तो सब के सब पॉजिटिव आ सकते हैं या एक बहुत बड़ी पोर्शन ऑफ दो सैंपल जो हैं दे विल बी पॉजिटिव फॉर द स्लेप लीजन एंड दे विल बी हैविंग नो सिम्टम दे विल बी एसिम्प्टोमेटिक तो ऐसे में थोड़ी सी एहतियात करनी चाहिए sometimes we have to decide on the clinical sign and symptoms. If the patient is asymptomatic, so then doesn't matter what are the signs, what are the characteristic sign on the MR. So this is the arthrogram procedure, interior approach of the needle for the image-guided green humeral joint injection of the contrast material using the CT scan and the MRI, but ultrasound is also used for this purpose. The endemic rate of variation of labral anatomy visible on MRI is asymptomatic the threshold should prompt caution before concluding that the labrum is the source of the patient, specifically in the asymptomatic. तो थोड़ा सा जो इसमें एहतियात करनी चाहिए before that labrum is the source, declaring that the labrum is the source of the Schwarzberg reported MRI document of slave lesion can be present in up to 72% of middle-age asymptomatic patients. So this is very huge amount. Asymptomatic patient में 72% जो है slave lesion मौजूद हो सकती है इसके अलावा जो है ये और भी बहुत इम्पोर्टेंट है कि बाकी जो शुल्क पितारी चीज़ें इसको भी हम न सिर्फ रिकग्नाइज करें बल्कि इसकी इंटेंसिटी के साथ साथ इसको डिटेक्ट करें और इसको एक्सक्लूड करें या इंक्लूड करें इसका डिफरेंशियल डायग्नोसिस बहुत ज़रूरी है और स्पेसिफिकली बोथ इंटरनल एंड एक्सटर्नल इम्पेचमेंट सिंड्रोम डिटेल सैंपल चुके हैं रोटेटर कफ सिंड्रोम द लॉन्ग हेड ऑफ बाइसेप टेंडन उसकी टेंडिनोपैथी क्रोनिक न्यूक्लियर आर्थराइटिस और द एसी जो डिस्टल क्लेविकल है उसकी ऑस्टियोलाइसिस है या स्प्रेन ऑफ द एक्रोमिक क्लेविकुलर तो इन तमाम को जो है क्योंकि ये तमाम की तमाम कंडीशन जो है स्पेसिफिकली दिस आर्थराइटिस आर्थराइटिस एंड रोटेटर कफ सिंड्रोम एंड इम्पेचमेंट दे ये मिडिल एज पॉपुलेशन में जो है भी प्रेजेंट होते हैं। इसलिए ज्यादातर जो फोकस होती है स्लेव रीजन पे, या मे बी either over appreciated or misdirected. So that's why there should be the therapist at the physician, they should be very careful. As mentioned, this concept can also be applied to the young athletic population as well. According to a study published in 2005, an MRI analysis of professional handball players demonstrated abnormalities in 93% of shoulder, with only 37 being symptomatic, and the remaining 63% they were asymptomatic. Again, this is a very huge amount of and huge high numbers, that 63% of the handball players, elite players, they were with slave region and the MR, but they were asymptomatic. So at 1.5 Tesla is actually the that unit used for the quantification of for the strength of the magnetic field. Usually 1.5 Tesla is used commonly. So in some advanced and large hospitals, 3 Tesla magnetic resonance imaging scanners, they can be also used. In some high level institutes, 7 Tesla भी यूज होती हैं, लेकिन ज्यादातर जो 7 टेस्ला होती हैं और रिसर्च पर्पस के लिए यूज होती हैं, न्यूरो साइंसेज में बहुत कम यूज होती हैं। जस्ट लाइक दैट, क्या नाम था उसका, पेरिस इंस्टीट्यूट ऑफ न्यूरो साइंसेज जो है उसमें 7 टेस्ला जो है ये यूज होती है। तो ये 7 टेस्ला, ये टेस्ला जो है, दिस इज एक्चुअली इसका इन्वेंटर जो था, उसके बाद उसका नाम उसके नाम पर रखा गया है। So 1.5 Tesla, it's commonly used, but as the strength of that magnetic field increases, so obviously image की जो क्वालिटी है, न सिर्फ क्वालिटी इंप्रूव हो जाएगी, बल्कि यहाँ पे जो डिलिकेट से डिलिकेट रीजन है, वो भी जो है आइडेंटिफाई होने में आसानी हो जाती है। तो इसलिए हायर द टेस्ला जो है, ये इसकी सेंसिटिविटी इंप्रूव कर देती है। At 1.5 Tesla magnetic resonance arteriogram MRI, a magnetic resonance imaging exam with intraarticular injection of a dilute gadolinium. Gadolinium is exactly that contrast agent which can be injected into the shoulder, is more accurate than conventional shoulder MRI for the diagnosis of slab tears and obviously जैसे हमने कहा, इसकी वजह से जो है इसकी सेंसिटिविटी जो है ये improve हो जाती है। What we mean by the sensitivity? Sensitivity is the the rate of true positive divided by all disease patient। यानी जितनी भी रियल डिजीज पेशेंट है, यानी जिनमें एक्चुअली देयर इज लीजन, तो एमआरआई कितने में डायग्नोस करेगा, कितने में रिपोर्ट करेगा यस दे हैव द डिजीज, सो दैट द ट्रू पॉजिटिव रेट डिवाइडेड बाय ऑल द डिजीज पीपल, they will be called as the sensitivity। और हम इस तरह भी कह सकते हैं कि the true positive divided rate of true positive divided by the जितनी भी यहाँ पे ट्रू पॉजिटिव है, और वी कैन से दैट फॉल्स नेगेटिव जो है, इन दोनों को कंबाइन कर और इसमें जो ट्रू पॉजिटिव होगी दैट वुड बी द सेंसिटिविटी। तो ये जो कंट्रास्ट मीडियम है, ये इट इज मोर एक्यूरेट बिकॉज ये विजिबिलिटी थोड़ी सी इंक्रीज करती है। मिसाल के तौर पर एक मेटा एनालिसिस जिसमें 4667 शोल्डर्स की एनालिसिस की गई, और ये 4570 पेशेंट की इमेजेस थी, और उन सब की जो कंपैरिजन जो एमआर की गई थी, दैट वाज ऑन 1.5 टेस्ला strength of MRI versus MRI font sensitivity of 83 versus 79% and specificities of 93 versus 87% respective। यानी जो MRI है उसकी ऑर्थोग्राम की, इसकी जो सेंसिटिविटी थी ये 83 थी, एंड एमआरआई की जो सेंसिटिविटी थी वो 79 थी। इस तरह अगर स्पेसिफिसिटी की बात कर ले विच इज एक्चुअली द rate of true negative divided by all the healthy people. So that rate of true negative is known as specificity, while the rate of true positive is known as the sensitivity. This is the true positive divided by all the disease people, and this is the true negative divided by all the healthy people. So the specificities of MRI there was 93, which was much better than 87, which was for the MRI. So again, it's according to the MR, जो arthrogram had that is more accurate in these diagnostic parameters as compared to the MRI. अब अगर स्लैब लीजन मौजूद है और इस पर एमआर की जाती है, सो व्हाट आर द डिफरेंट कैरेक्टरिस्टिक जो एक एमआर रिपोर्ट में आ जाएगी, व्हाट इज द डायग्नोस्टिक क्राइटेरिया फॉर द स्लैब लीजन, कौन कौन सी ऐसी कैरेक्टरिस्टिक फीचर्स है एमआर में जिसके बाद रेडियोग्राफर दैट विल जो रेडियोलॉजिस्ट है वो डिसाइड करेगा और कि पेशेंट इज हैविंग स्लैब लीजन। तो सबसे पहले जो है दिस इज जो लेब्रम है सुपीरियर लेब्रम, उसकी लेटरल कर्विंग होगी और वहां पे ब्राइटनेस ज्यादा होगी, हाई सिग्नल इंटेंसिटी होगी, यानी हाइपर इंटेंसिटी होगी कोरोनल इमेज। सिमिलरली वहां पे जो है ये ब्रांचिंग होगी, यानी ब्रांचिंग लाइन ऑफ द हाई इन सिग्नल इंटेंसिटी स्पेसिफिकली कोरोनल इमेज पे टॉप जो सुपीरियर लेब्रम है ऑन दैट उसमें। सिमिलरली डिटैचमेंट, full thickness detachment, irregularity marginated, high signal intensity or separation of more than 2 millimeter on the conventional MRI or 3 millimeter on the MRI radiography. अगर MRI है, so more than 2 millimeter, and if it is orthography, so that is more than 3 mm. Between the labrum and granite and a coronal image is considered as full thickness detachment. हम आगे image भी आप लोगों के साथ share करें. And the last one is the presence of a parallel cyst extending from the superior labrum. ये cyst जो है ये फ्लूइड फिल्ड होती हैं और फिर इसकी मुख्तलिफ डायरेक्शंस होती हैं। ये इंटीरियर भी प्रेजेंट हो सकती है, पोस्टीरियर भी प्रेजेंट हो सकती है, ऊपर भी हो सकती है, नीचे भी हो सकती हैं। और cyst जब भी बनी होती हैं, so cyst they can be diagnosed on the ultrasound as well as they can also be diagnosed with the MR, but अल्ट्रासाउंड से ये इजीली जो है हो सकते हैं। एम जो स्लेप रीजन है ये थोड़ा सा अल्ट्रासाउंड से मुश्किल हो जाता है, लेकिन पैरालिब्रोसिस जो है दे कैन बी इजीली डायग्नोस्ड एंड डिटेक्ट ऑन द अल्ट्रासाउंड। तो पैरालिब्रोसिस जो है ये बेसिकली कॉम्प्लिकेशन ऑफ द लीजन है। जब ये सुपीरियर लेब्रम जो है इसकी लीजन हो जाती है, सो इट डेवलप इनटू पैरालेब्रल सिस्ट। इसके बाद जो है ये सिस्ट बनते हैं। So this is the comparison of the normal shoulder, and this is actually we can see here the hyper intensity high signal आ रहे हैं यहाँ पे। This is the granite cavity, and this is there is a separation between this is that slab and this is the granite labrum. So this is a separation, and the brightness indicate that there is the lesion. This is the normal labrum. This is the granite cavity. This is the that's superior labrum, and this is the humeral head. There's another image showing this is the sign where it indicates that there is detachment or a lesion in the superior labrum. So these all images are regarding the full thickness or detachment with the linear signals separating the superior labrum from the granite rim. You can see here यहाँ पे आपको एक वाइडनेस नजर आएगी, फिर यहाँ पे आपको नजर आ जाएगी, यहाँ पर ये हम एक कट जो है यहाँ देख सकते हैं। सो इन तीनों इमेजेस में ये अलग अलग पेशेंट के हैं और ये तीनों में हम यहाँ पे देख सकते हैं कि देयर इज separate clear separation of that superior labrum from the rim. This is actually the granite rim. This is the separation. ये यहाँ पर ये आप देख सकते हैं, and this is the so in तीनों में this is another criteria which is the full thickness detachment with from the superior labrum from the glenoid vein. We can see here this is and this यहाँ पे आप ये देख सकते हैं. This is the slab region. This is the slab region. Slab 2 and these are this ये जो आपको circle नजर आ रही है are this one. These are the paralabral cyst. Paralabral means cyst present in the surrounding of the sides of the labrum. So actually ये दोनों जो हैं यहाँ पे हम देख सकते हैं. This is the continuation. ये this is the glenoid rim. यहाँ पे ये सेपरेशन हो चुकी है और ये जो सुपीरियर लेब्रम जो लेजन है ये जो है that lead towards the development of these uterine cysts. These are the two images showing the paralabral cyst. CT scan की तरफ आते हैं. Though MRI is the most appropriate and the gold standard for detecting the slab region, but there are some specific conditions where we can't use the MRI, just like the presence of pacemaker. क्योंकि pacemaker में there is an interaction of the strong magnetic field with the pacemaker, and that's why in such patient the MRI is contraindicated. खैर nowadays ऐसे pacemaker जो हैं ये बने advanced pacemaker जो हैं ये मिलते हैं which are safe to use for the MRI. यानी उसकी होते हुए जो है MRI को सेफ पे यूज किया जा सकता है. There is no such interaction of that magnetic field with the pacemaker. लेकिन चूंकि that may be not available, they are not very common, so that's why we have to be very careful. If the pacemaker is there, so then MRI is contraindicated. So फिर वहाँ पे जो है CT scan आर्थोग्राफी जो है ये एज ए सेकेंडरी मेडिकल इमेजिंग ऑप्शन के तौर पर जो इसको यूज किया जा सकता है. According to a retrospective review that included 161 imaging studies, the CT scan demonstrated a sensitivity and specificity of 94 to 97% of sensitivity and 72 to 76% of the specificity compared to arthroscope. So again, we can see here that they have a good sensitivity, but उनकी जो specificity है that is a moderate level. अल्ट्रासाउंड की बात की जाए the musculoskeletal ultrasound or the MSK ultrasound that is widely commonly used for the supraspinatus tear and other problems, but that is not useful and that is not very beneficial in the detection of the slab tears. The reason behind that is the labrum is surrounded by multiple osteostructure, and these osteostructure that make it very difficult to assess the slab region through the ultrasound. Labral tear may be associated with paralabral cysts or the bicep tendon abnormalities, and both the paralabral cyst and the bicep tendon tendinopathy or bicep tendonitis, they can be evaluated reliably using the ultrasound. Bicep tendon subluxation can be demonstrated on dynamic ultrasound, and this finding may raise suspicion of a type 2 slab lesion. क्या type 2 slab में जो टेंडन है ये इन्वॉल्व होता है, जबकि टाइप 1 में टाइप 3 में वहाँ पे जो है ये बाइसेप टेंडन इन्वॉल्व नहीं होता. डिफरेंशियल डायग्नोसिस जो है हम मुख्तलिफ जो पैथोलॉजीज हैं इनके साथ हमने करने और हमने इसको एक्सक्लूड करना है, और कुछ ऐसी पैथोलॉजीज होते हैं जो पेशेंट की पेन और उसकी डायरेक्ट जो है ऑब्जर्वेशन से ही हम इसको एक्सक्लूड करते हैं. यहाँ पे हम थोड़े से एक लिस्ट जो है आप पेश करें कि व्हाट आर द डिफरेंट पैथोलॉजीज व्हिच कैन बी differentially diagnosed and which can be used whenever there is in the screening of the shoulder pain. So there may be external and internal impingement syndrome, subacromial impingement syndrome, subcoracoid impingement, simply there may be calcific tendinitis. There may be slab region, that is the GERD, which means the glenohumeral internal rotation deficit, the little leak shoulder and the posterior labral tears. Similarly, the rotator pathology may partial versus full thickness tear and as well as the complete tear of the rotator cuff. RCA stand for the which that means for the rotator cuff tear. Advanced degenerative disease. It is a commonly known as the osteoarthritis. So the osteoarthritis of the shoulder, and these are often associated with the rotator cuff tear. Similarly, the craniohumeral arthritis, adhesive capsulitis, the frozen shoulder, avascular necrosis, and scapulothoracic nephritis. These all can be checked for the exclusion during the screening of the shoulder pain. Some conditions from the proximal bicep, that is subluxation, which most commonly seen experienced with the subscapularis injuries, tendinitis and tendinopathy, and as well as the slap tear. Condition of the acromioclavicular joint condition, the separation or the widening of the AC joint, the distal clavicle osteolysis, and the arthritis of the AC, as well as this separation is just secondary to the AC sprain जो इनके ligaments होते हैं एक sprain के बाद जो है there is chances of widening or we can say separation of the AC joint. So instability में both the unidirectional as well as the multi-directional instability as well as with the labral injuries of the neurovascular conditions suprascapular neuropathy can be treated with a paralabral cyst. इसलिए उसको जो है थोड़ा सा अगर पैरालेल सिस्टम मौजूद है तो ये भी देखना है कि वहां पे सुप्रास्केपुलर न्यूरोपैथी है कि नहीं एट द स्प्लेनेल नॉच. स्किपुलर विंगिंग दिखनी चाहिए कि मीडियल लैटरल ब्रेकियल न्यूराइटिस thoracic syndrome or quadrilateral stress syndrome. Other condition scapular thoracic dyskinesia was acromial, the muscle ruptures, pectoralis major, tetralis dorsi, and fracture. Acute injury or pain resulting from the long-standing deformity involving or the non. ट्रीटमेंट मैनेजमेंट की बात की जाए तो यहाँ पे मोस्ट ऑफ द स्लेप रीजन जो है ये कंजर्वेटिवली जो है ट्रीट हो जाते हैं और सम टाइम्स सर्जरी की भी जरूरत है. लेकिन ये बात भी जहन में रखनी चाहिए कि तमाम स्लेप रीजन जो है इसकी दे आर नॉट देयर इज नो इंडिकेशन ऑफ ट्रीट mean if there is symptoms but then तब जाके जो है we have to uh, formulate a treatment plan. Otherwise if the medical imaging they are showing some abnormal characteristic but the patient is asymptomatic so then we have to be very careful in providing the treatment and providing that plan for that person. It is essential to understand that not all the slap tears that created equal, and that's why the management for all the slab tiers that is also different. So it means the different types of slab region. There are 10 types of slab region. Every slab region is treated differently. So clinicians should focus on the potential relevance of the slab region as attribute to the specific patient, man, and dysfunction. Asymptomatic tears should also be observed. Those that are potentially contributing to the patient-reported symptom may require surgery. Otherwise, sometime in case there is no need of surgery and they can be treated conservatively, they can be treated with the physical therapy treatment. So that depend on that particular type of the slab region. साथ साथ जो है स्लैब के साथ कोई जो एसोसिएटेड पैथोलॉजीज हैं वो मौजूद, जैसे मिसाल के तौर पर उनके साथ जो है ये बाइसेप टेंडन इन्वॉल्व है कि नहीं है, उनके साथ जो ग्रीन ह्यूमरल लिगामेंट ये इन्वॉल्व है कि नहीं है, वहाँ पे पिंक कॉट लीजन है कि नहीं है, तो एक पैप जो है वहाँ पे अनस्टेबल पैप है कि नहीं है, तो ये बहुत और भी सारे ट्रेका पे इन्वॉल्वमेंट, ये जितनी भी एसोसिएटेड पैथोलॉजीज है इनकी भी जो है इवैल्यूएशन होनी चाहिए कि दे आर प्रेजेंट और दे आर एब्सेंट. Moreover, for the vast majority of the slap injuries, the initial management is non-operative. अब non-operative में हम क्या कह सकते हैं, initially if it is the acute so anti-inflammatory insert जो है ये दी जा सकती है, आइसिंग जो है क्रायोथेरेपी ये दिया जा सकती है, कूलिंग एंड आइसिफिकेशन इसके अलावा रेस्ट एंड एक्टिविटी modification is very important because if there is कुछ स्पेसिफिक मूवमेंट जो उसको रेस्ट्रिक्ट नहीं किया जाए तो मैट जो है वो जो लेजन है इसको ट्रीट होने के बजाय ये और भी वर्सन हो जाएगा. An initial period of rest following the acute or acute and chronic injury should be implemented in all patients. और ये इसलिए जरूरी है ताकि उस लेबरम के लिए जिसके लिए उसकी हीलिंग में थोड़ी सी उसको वक्त मिल सके. In the appropriate patient, the use of NSAID and crab therapy devices medication can be very beneficial for the control of the pain intensity. जो एथलीट्स होते हैं या ओवरहेड लेबरर्स होते हैं उनमें ट्रीटमेंट के साथ साथ जो है उनकी कुछ स्पेसिफिक जो रिस्ट्रिक्शन है ये भी कंसिडर की है जरूरी है. और इसी तरह जो लेबरर्स होते हैं जो ओवरहेड लेबरर्स होते हैं सो देयर इज नीड ऑफ सम मॉडिफिकेशन इन देयर ऑक्यूपेशन. अदरवाइज ये थोड़ा सा आप उसको रेस्ट ले सकते हैं या जीवन में उसकी थोड़ा सा ऐसे काम करे जिसमें से ओवरहेड जो है ज्यादा इन्वॉल्व ना हो. फिजिकल थेरेपी जो है इसमें डिफरेंट मोडिलिटीज यूज कर सकते हैं. सिमिलरली हम फिजिकल थेरेपी का एक गोल ये भी होता है यहाँ पे जो अल्टर्ड बायोमैकेनिक्स होता है उसको हम जो है करेक्ट कर दें. साथ साथ यहाँ पे जो रिक्वायर्ड मसल्स हैं उनकी जो टाइट मसल्स है उनकी स्ट्रेचिंग और जो वीक मसल है उनकी स्ट्रेनिंग पे उनकी जो इम्बैलेंस है उसको बैलेंस करने के लिए और इस कोऑर्डिनेशन के लिए फिजिकल थेरेपी एक्सरसाइजेस दैट कैन बी वेरी हेल्प. Similarly, if there is scapulodyskinesia, so we have to initially to diagnose that is the type 1, this is the type 2 or the type 3. As in the type 1, there is only the anterior angle prominent, while in the type 2, the medial, complete entire medial border is prominent, and the type 3, there is the superior border. तो जिसे अगर टाइप 3 में देखा जाए तो वहाँ पे इम्बेलेंस होता है रेशो स्ट्रेंथ रेशो होता है उसमें इम्बेलेंस आ जाता है बिटवीन द अपर ट्रेपीजियस एंड लोअर ट्रेपीजियस. सो लोअर ट्रेपीजियस जो है ये वीक हो जाता है अपर ट्रेपीजियस ओवर एक्टिव हो जाता है. so that's why we as a physical therapist we can we can work on that balancing the ratio between the upper trap and lower trap. Similarly, if this is the type 2, so we can strengthen the boxer muscle, we can strengthen the interior serratus anterior muscles. So ये जो है ये important है if we have that proper diagnosis and as well as the identification and evaluation of the situated pathologies. So physical therapy can help in the achieving the better outcomes. इसके अलावा जो है पोस्टीरियर शोल्डर कैप्सूल जो है उसकी हेल्थ देखनी चाहिए उसकी स्टेटस देखनी चाहिए बिकॉज सम हाउ दिस इज वेरी प्रोन टुवर्ड्स द टाइटनेस और इसकी कंट्रैक्चर इसकी वजह से जो है फिर मुख्तलिफ स्टिचिंग है. ये हम जैसे जैसे लाइक द क्रॉस द बॉडी स्ट्रेच है या स्लीपर स्ट्रेच है. these two are the very important stretch used for the stretching of the posterior capsule tightness of the shoulder. Utilizing dedicated formal video regimes can help ensure each diagnosis is most adequately managed to help the mitigation of the risk of the inferior patient outcome. Inferior patient outcomes से मुराद ये जो poor outcomes. Multiple reports on high level overhead tours have demonstrated equivalent outcomes. ये बहुत important है कि regarding return to play and return to play execution or performance in athletes managed with operative versus non-operative model alone. So वहाँ पे equivalent outcome जो है it means there is no superiority between the operative management or the non-operative management. Both were equal in that outcome, specifically the pain relief, return to play, and that muscle activity and and activity and just like the performance like for the step. Non-operative PT regimes focused on the correcting for the scapulodyskinesia and cleaning internal rotation deficit, which we discussed in the previous slide. If the non-operative therapy fails and symptoms persist that prevent sports activities or activities of daily living, then this would indicate the need for the operative treatment. Surgical management that depend which type of slave region is present. So, for a orthopedic surgeon, that is very important, and this is very imperative to identify specific type of slave region because every slave region is having different surgical management. Uh, if we consider the slave one, if we consider the slave two, then slave three, so every type of slave has different surgical management. So these are some of the recommendation. These are the algorithm for the different type of treatment and which type of surgical management is required. So if it is just a type 1 slip tear, when there is just degeneration and there is no involvement, there is not involvement of the bicep tendon is okay and intact. Simply there may be arthroscopic need of the arthroscopic debridement. But on the other hand, if it is the type 2 slab tear, then in the surgical management, slab repair is required, plus there may be need of the bicep tenotomy or the tenodesis. Tenotomy means the surgical removal of the bicep tendon, and the tenodesis simply means the reattachment of the any tendon to a bone or again to another tendon. In both cases, it will be called as that surgical procedure used to reunite the reattachment of the tendon to the bone is known as the tenodesis. So the बाइसेप टेनोटमी और टेनोडेसिस जो है इसका भी एक क्राइटेरिया है कि अगर ये 50% से जो है ये ज्यादा है कम है वो आगे हम डिस्कस करेंगे तो फिर हमने क्या करना है सही है The arthroscopic criteria for a slab tool lesion includes the ability to demonstrate, usually with an arthroscopic probe, the definitive separation of the superior labrum from the supraglycinate cartilage rim. और यही जो है डिस्कस किया था बुरकाट ने इसको पील बैक मैकेनिज्म और उसने आर्थ्रोस्कोपिक में ये इसको डिस्क्राइब किया था पहली बार जो टाइप 3 स्लेब टीयर है इसमें जो सर्जिकल मैनेजमेंट होगी वो ऑब्वियसली स्लेब रिपेयर तो होगा लेकिन उसके साथ साथ रिसेक्शन होगी किस चीज की रिसेक्शन होगी वो जो बकेट हैंड बिकॉज टाइप 3 का जो करेक्टरिस्टिक है वो क्या है दिस इज द बकेट हैंडेड डिफॉर्मिटी और ये बकेट हैंडेड टीयर ऑफ सुपीरियर लेब्रम जो है इसको रिसेक्ट किया जाता है टाइप 4 स्लेब टीयर जो है इसका सर्जिकल ट्रीटमेंट जो है इसमें डिपेंड करता है कि बाइसेप टेंडन की इन्वॉल्वमेंट कितनी है less than 50% of the bicep tendon is affected तो फिर उसके साथ जो है सिर्फ slab repair हो सकती है with along with the resection and if there is more than 50% of the bicep tendon is affected तो फिर वहाँ पे tenotomy जो है या ट्रेडिशनली हो सकती है and the type 5 slab tear where there is a Bankert involvement so स्लैब रिपेयर के साथ साथ जो है बिंग कार्ड रिपेयर भी जरूरी है टाइप 6 स्लैब टियर वहाँ पे जो है स्लैब रिपेयर वर्सेस रिसेक्शन एंड टाइप 7 पे वहाँ पे एंकरिंग फिक्सेशन ऑफ द इंटीरियर सुपीरियर लेब्रम साथ साथ जो है विद द स्लैब रिपेयर जो in the type 8 slab tear surgical management is the slab repair versus bicep tenotomy and the tenodesis gentle debridement of any cartilage or condyle unstable प्रोग्नोसिस जो है मुख्तलिफ स्टडीज जब वो यही शो कर रहे हैं कि आफ्टर द ट्रीटमेंट दे हैव गुड रिजल्ट्स एंड गुड आउटकम्स एंड here in some of the patient there is successful return to sports so that's a good thing and that depend on the management mostly these outcomes these are after the surgical procedures. The number of authors report good results in athletes, including those with sport-specific overhead demand requirements. Clinicians should recognize that poor outcomes have been demonstrated in the literature performing revision arthroscopic slab repairs and high level are the elite होते हैं professional athletes. Professional baseball pitchers demonstrate relatively poor outcome in terms of return to play and return to pre-performance level. In fact, superior outcomes have been reported in this particular subset of athletic population involving non-surgical management alone. और ये हमने पहले भी कहा है कि मुख्तलिफ एविडेंस आ सकती है। पहले हमने कहा कि according to that study, surgical management and the non-surgical management were almost equal in that patient outcomes, including the pain relief, including the return to sports. And regarding the regain of the pre-injury level of the sports, यहाँ पे जो है in this study, they have both studies have reported that surgical management के बाद patient की जो outcome थी they were superior as compared to that surgical treatment, यानी जिसमें सर्जिकल ट्रीटमेंट नहीं की गई थी, सिंपल सिर्फ नॉन सर्जिकल ट्रीटमेंट की थी, उसमें जो आउटकम थे ये सुपीरियर आउटकम थे एज कम्पेयर टू दोज जहाँ पे इसी प्रीवियस स्टडी में कि जहाँ पे ये आर्थोस्कोपिक रिपेयर की गई थी, तो उनमें आउटकम जो ये पुअर थी, वी कैन से दैट एंड सुपीरियर आउटकम्स। तो ये कंट्रास्ट आ रही है उस स्टडी से और इस स्टडी की, ये यहाँ पे स्लैब रिपेयर की जो आउटकम ये पुअर थे, वाइल नॉन सर्जिकल मैनेजमेंट की सुपीरियर आउटकम्स थे, और वहाँ पे showing that both are equal in regarding the patient outcome. Risk factors for the revision surgery, they are very critical in discussing overall patient expectation and discussing the risk of continued pain, stiffness, dysfunction, and the potential need for further surgery in the future. Multiple risk factors have been reported in different studies. A study published in 2017, they are reported with the inclusion of nearly 5,000 patients in the database. And according to this study, the various risk factors for the complication are the risk factors for that revision surgery. They are the age greater than 40 years, the female gender, the obesity, smoking, and the presence of the concomitant long head bicep tendonitis or the tendinosis. If there is surgical management of the patient, so then the post-op rehabilitation, that is very crucial and very important. So we can divide them into four phases, that is from 0 to 4 or 6 week after the post-op, then week 4 to 6 post-op, or that may be from the 6 to 12 post-op, and then the last one that is after the week 12 and beyond. So in the initial 4 weeks or 6 weeks, there will be immobilization in the sting, specifically the initial 4 weeks, and then early shoulder pendulum exercises, periscapular muscle activation exercises, they can be provided for the patient. They can be included in the protocol for the post-op rehabilitation plan. Similarly, the passive and active assist forward elevation should be encouraged, and there may progress limitation depending on the surgeon preference. Avoid extremes of abduction and external rotation, as this may lead towards that feedback mechanism जिसमें जो tendon होता है bicep का, ये twist हो जाता है, और ये that will lead to the slap, they may lead to the lesion and tear in the superior labrum. So that's why यहाँ पे जो restriction है, that would be the external rotation at the after the 90 degree abduction. अगर abduction rotation आप neutral पे करी या lower range पे करी, तो might be there is not so dangerous, but if the external rotation is executed at 90 degree of the abduction of the shoulder, so then this may be very dangerous and may have a very negative impact on the superior labrum. In the second phase, incorporation of the range of motion should be started, and again in this phase there should be the therapy should be very careful, and the extreme abduction should be avoided. In the third phase, from 6 to 12 post-op, functional exercises and light standing can be progressively incorporated. And then it's okay to begin bicep resistance exercises beyond 6 to 8 post-op. Resisted elbow flexion, resisted for observation. There is no such problem with these exercises. And week 12 and above that, advanced training and running Japanese sport specific training and typical return to sports around 6 month में ये फिर गोल में हमारी होनी चाहिए. That was the end of the evaluation, the medical imaging as well as the surgical and physical therapy management and as well as the prognosis and complication in the respectors of the lab. Thank you so much to all of you. Have a nice day. Allah